Good morning everyone, my name is Michelle and this is a very brief overview of an audit that was completed last year looking at the performance of pre-operative anaesthetic assessments performed at PA Hospital and QE2 Hospital in Brisbane, Queensland, Australia. The aim of this audit was to determine if there were consistent pre-operative anaesthetic assessments being performed as per ANZCA guidelines, to assess the adequacy of documentation, to determine if an early pre-anaesthetic assessment correlated with better post-operative outcome, to identify any anaesthetic complications, to address any issues and barriers, and to provide data that may be used in comparison for future audit cycles. Now, here are some images showing a breakdown of results. You can see that most patients were assessed on the day of surgery, ranging across many surgical departments, and most of these patients received either a GA or sedation. The key findings that we found showed that there was a combined majority of 69.5% of patients assessed on the day of surgery, and only 30.5% of patients assessed 1 to 2 months ahead of time in the pre-admission clinics. Now, according to the guidelines, ideally all patients should be reviewed prior to admission. Otherwise, admission times and lists should be pushed back in order to accommodate for extra time that is required for the pre-anaesthetic consults. A total of 2% of patients across PA and QE2 do not have any documentation of a pre-anaesthetic assessment, and this posed a large medico-legal risk. Only 3 out of 200 anaesthetic-related complications were identified, however, 2 of these complications being assessed in the pre-admission clinics and 1 assessed on the day of surgery. This highlights the importance of an early pre-anaesthetic assessment prior to surgery in order to identify complications and to allow for planning of anaesthetics. However, it also demonstrates that an early assessment in clinics does not necessarily correlate with improved patient outcomes. Therefore, ideally, both an assessment in clinics and on the day of surgery is important for patient safety. All of the emergency cases were assessed on the day of surgery, as were patients who underwent a scope, and most of the opthal cases at PA Hospital were assessed on the day of surgery, assuming this was likely due to low nature of anaesthetic and surgical risk. An anomaly that we did come across was a cardiothoracic patient who was undergoing a lobectomy of the lung. This patient was only assessed on the day of surgery and also lacked any formal documentation of their pre-anaesthetic assessment. Fortunately, however, there were no associated complications for this case. So overall, our main learning points: a thorough pre-anaesthetic assessment prior to any surgical procedure remains one of the most important factors in patient safety, and documentation of the pre-anaesthetic assessment is always mandatory. Realistically, it might be challenging to perform a full assessment ahead of time, especially in emergency cases. However, it should never be omitted. Perhaps a way to improve our current clinical practice will be to reinforce our guidelines and also to create an electronic safety checkpoint on our documentation system. A continuous audit cycle will also be important in establishing areas that require further improvement.